important to underline up front that this protocol was for all adults, meaning that was for patients with 18 years of age upwards, with no upper age limit. And in fact, in a study, there were very elderly patients that were recruited. So this study was based on an extension of the philosophy that the GIMEMA corporate study group in Italy has had for many years, is that of using an induction only a TKI, so tyrosine kinase inhibitor plus steroids and no systemic chemo. So this started very many years ago. This philosophy we adopted more than 15 years ago. In fact, the first paper was published in Blood, and it was published, if I remember well, in 2007, so that's 14 years ago. So the study started earlier, so it's well over 15 years. And the idea came obviously from CML, where you control the patient with a TKI alone. So we said, why don't we consider doing this in the Philadelphia positive ALL patients too? And we started with the elderly. So the first study with imatinib was for patients above the age of 60 with no upper age limit. And in fact, the oldest patient was 89. And all patients responded and all went into remission, which was very rewarding, particularly for the elderly, because in the older days, for the elderly patients, we didn't have anything to offer. Many even got only palliative treatment because there was very little to offer. So that was the start of a long story, and we went on over the years using second-generation inhibitors, namely Dasatinib, then we went to Blinatumomab, so a number of studies, and they're more or less all published. So this last study, which is the D-ALBA protocol, we added a further important step, which is the consolidation. So it's induction with Dasatinib and steroids, but then the consolidation is for all patients. Irrespective of response obtained with Dasatinib, they all get immunotherapy with a monoclonal antibody, Blinatumomab, bispecific. So it's a form of immunotherapy because the antibody, as you know, targets the CD19, which is present on leukemic B-ALL cells, but that the therapeutic effect is mediated by the CD3 component. So it targets the second antigen, targeted CD3, so it's activating the host immune system of the patient itself, so CD3 cells. So it's a form of immunotherapy. So it was induction and consolidation without any systemic chemo. So the two key points were and have always been that you have to identify the Philadelphia chromosome-positive in all patients rapidly in the 1 week of steroid prephase. And the second is that you have to give CNS prophylaxis. So the only chemotherapy they get is in cerebrospinal fluid. So the data of this study were published in the New England Journal last fall, and it was very rewarding. All patients went into remission, and we obtained at the primary endpoint, which is after 2 cycles of Blinatumomab, we obtained 60% of molecular responses, which increased after more cycles of Blina up to about 80%. Now, what's happening at DHA is that Sabina Chiaretti has presented the update of our study, and which is, I must say, rather rewarding, because the data continue to look very promising in terms of responses and of molecular responses. And in fact, we have data that are projected at 3 years follow-up with responses which remain very good. And to give you the exact figures, but off by heart, I never remember them, but at projection at 3 years, we have 80% of overall survival, and the disease-free survival is 71%. So this is extremely good in patients. And I must say that half of the patients so far have only received a TKI, so no chemotherapy and no transplant. Another proportion of patients have gone to transplant. What has emerged again and confirms and extends what we observed in what we report in New England is a rate of molecular responses that is well over 80% and continues to be so over time. The other important point is MRD, key point. This we said, we reported it in the publication, and it continues to be the case over time. Patients who obtain a molecular response, virtual negative by quantitative PCR, remain without events, particularly if they don't have additional genetic abnormalities at diagnosis. If you have a Nicaros plus, genetic profile at diagnosis, these patients do significantly less well. The update of the curve is 79% of disease-free survival if you don't have any genetic abnormality at diagnosis, 55% if it's Icarus alone, and down to 41% if it's Icarus plus. So the genetic landscape at diagnosis is very important in order to actually define the prognosis of patients. So this is where we stand, and I think it's very important to underline. I should also, one final point is that the study was only stopped at the end of the consolidation. That was a primary endpoint. After that, the patients were free, the centers were free to treat patients as they wanted, and they were collecting all the data. And so far, after the patients have been transplanted, and what is important is that the transplant-related mortality is low. And that is most likely because they haven't had systemic chemotherapy. So this, I think, is a very important point that leads us to probably change the strategy of the management for Philadelphia positive ALL, at least in adult life.